Hello. Hi, this is Dr. Don Bonner. We're going to start our Facebook Live presentation tonight. It's 4 o'clock, and welcome everybody. And today we're going to talk about estrogen. And really, estrogen, I labeled this estrogen after menopause, but it could be menopause or surgical menopause or, basically when you have low estrogen levels and replacement. So again, Dr. Don Bonner, and that's our phone number at the clinic, 601-898-0911, and give us a call and make an appointment, come see us. So let's see, let's bring up the PowerPoint here. Here we go. That's me. And real quick, we'll just go over my biography to people who don't know who I am. I'm an osteopathic physician, so I'm a DO, and I received my medical degree in 1991. I did a rotating internship in Iowa from 91 to 92. Did my anesthesiology residency at the University of Mississippi from 92 to 95. Was board certified in 1995, and I've been in private practice from 1995 to the present time as an anesthesiologist. Several years ago, I guess 4, 5, 6 years ago, I just became interested in this type of medicine, and anyway, I became board certified in it's not anti-aging. It's through the American Academy of Anti-Aging Medicine, but the board certifications in metabolic and nutritional medicine, and then the fellowship that I have is through the same organization. And the fellowship took about 4 years or so. There was 8 modules, so it's a really nice fellowship though, and I learned a lot. What I like to do initially, and people that know me and that see me in the clinic know that what I do is I reverse engineer the things that are really going to harm us as we get older, and so I look at mortality statistics of people that are older than 40 and non-smokers, and by far number one is cardiovascular disease and cerebral vascular disease and stroke. So I really, talk to all my patients about my concern with those two entities and what we need to do to decrease their risk for those particular problems. And that's going to segue into today's talk with estrogen. And I'll get on my soapbox about estrogen today. Number 2 is cancer. Number 3 is neurodegenerative diseases, Alzheimer's, Parkinson's disease. Number 4 are accidents, mainly motor vehicle accidents until you get older. Now the things that we can do to affect our health are diet, nutrition, sleep, stress management, exercise, and then hormones. And today we're going to be talking about hormones. Specifically, we're going to be talking about estrogen and estrogen replacement therapy. So what exactly are hormones? Again, I put this slide in here on nearly every talk. Hormones are just a messenger system that are in your body that are secreted from one organ, and they go throughout your body to different cells and organs of the body to affect a change, some sort of a change. So it's just a messenger system, and they work with your cells in a lock and key fashion. So you have to have specific receptors for that specific hormone. Today, again, we're going to be talking about bioidentical hormone replacement, and my method of bioidentical hormone replacement is with pellets. I'm a big believer in pellets. That's pretty much all I use. I don't use creams and gels anymore or shots as far as testosterone goes. Almost exclusively pellets. And we'll go into why I like pellets in just a few moments. But the biggest question that I ask when patients come to the clinic is how do you feel? I mean, when we go through your history and your physical, um, the main thing that I want to know is how do you feel right now? And we'll go into your symptoms and what's going on with your life. And this is pretty close to how a lot of people feel throughout the day. Uh, and again, do you have headaches? Are you putting on weight? Do you have trouble losing weight? Just typical things that we see. And obviously, this is what we want to see. We want to see vibrant, healthy people. This is not a process of anti-aging. I don't like that term. I think it's silly. We're all going to age, hopefully, but it's how you age that's important, and that's what we do here at the clinic. And my focus, we want you to age well, to be vibrant, and till your last days, and because nobody wants to live. That's part of the problem that we have in medicine right now with our acute care model. We're really good at keeping people alive, but it's that quality of life, especially that last 5 to 10 years, can be, you can have just not a very good quality of life. And that's what we're after. So, hormone havoc, so we're going to kind of go into the issues that you can have with hormones. And this is specifically uh, addressed to women today, as far as the talk today. And I can tell you that those perimenopausal years for my patients up to menopause can be pretty tumultuous years that your hormones are all over the place. I was seeing a patient today that was perimenopausal, and that just there's no way of knowing where they are in the month as far as their hormones. Their estrogen and progesterone can be all over the map. So pretty difficult to treat during that period of time. And menopause is by definition when you have not had a menstrual cycle period for 1 year, and then you're considered to be in menopause. So 3,500 women enter menopause daily, and but those symptoms can begin up to 15 years before that. That perimenopausal period is again very tumultuous for a lot of people, and the thing that I see, and I think it's changing. I hope it is anyway. Is that I see a number of women that have had basically a surgical menopause or menopause be told that they don't really need hormones. And that's going to be the soapbox for the day. I very much disagree with that statement. And I definitely think women need estrogen replacement after they go through menopause. And we'll go through those reasons here in a moment. So estrogen is present in both men and women. And, men, obviously, we don't want a lot of estrogen. And obviously, we'll measure that when we replace testosterone. But, women definitely need their estrogen. And look at that 400 functions in the body. And I definitely agree with that. So just imagine you've been told that you don't need your estrogen after you go through menopause. There's basically 400 functions that aren't going to be accomplished because you're not taking your estrogen. So, we want to control your hot flashes for sure, and bone density. We want to maintain your memory, the collagen in your skin. But really the biggest thing that we want to maintain for women is their cardiovascular health. And in my opinion, you need to replace estrogen to have the highest quality of cardiovascular protection. Here's what this is where most of the trouble came from for estrogen and hormone replacement for women. The Women's Health Initiative was set up in the late 90s, and it was supposed to show that hormone replacement therapy prevented cardiovascular disease. Well, it had to be stopped in 2002 because the study was alarming. Look at these numbers. There's an increase in stroke, heart attacks, breast cancer, blood clots, Alzheimer's, dementia. It was a disaster. So consequently, in 2002, many women stopped taking hormone replacement therapy. The big problem with this study, well, there were several problems, but the biggest problem is the drug that was used, Prempro, which was Premarin and Provera. It was a combination of synthetic estrogen and synthetic progesterone taken orally, and that was a huge problem. So there's the first number one on the list. It was the wrong hormone. It was the wrong route of administration. So we don't want to take estrogen by mouth, and I don't give estrogen by mouth. Uh, the median age of the women in the study was actually 65 years old when they started the study. So if you agree with what I've put out just a few moments ago, that your risk of cardiovascular disease increases with menopause, these were women that had an increased risk for cardiovascular disease for up to 15 or more years. And so that was a problem. And interesting enough, when you looked at the group of women between ages 50 and 59, they actually had a decrease in cardiovascular events, even though it was a flawed study from the drug that was given. The other thing that was interesting was that the estrogen-only arm of the study actually showed no increase in breast cancer. So that was interesting. So women that had had a hysterectomy in the past didn't need to be on did not need to be on progesterone. So the Provera portion was taken out. They were just given Premarin, and they had no increased risk of breast cancer. So that's fascinating. The big problem with the study, for the most part, was Provera. Provera increases your risk of stroke, cardiovascular disease, breast cancer, blood clots. It's just, in my opinion, not a very good drug. Since that time, there's been a bunch of studies that have come out. This one is the Nurses' Health Study. Again, it showed conjugated estrogens increase your risk of breast cancer. So that was Premarin. But interesting enough, it showed that estrogen plus testosterone, there was no increased risk of breast cancer. So I think that's a very interesting study. And again, this has hundreds of studies that the take-home point is that testosterone delivered by pellets, they do not increase your risk of breast cancer, and frankly, probably decrease your risk of breast cancer. And that treatment with testosterone and estradiol implants do not increase the risk of breast cancer. As a matter of fact, even with breast cancer survivors, testosterone is allowed to be placed into these patients. So that's something that's interesting. This is Susan Davis that was published in Menopause. The conclusion was with estrogen replacement with pellets that body fat was you had a decrease in visceral fat, essentially, in lipid parameters, decreased cholesterol and LDL, increased HDL, decreased triglycerides. Lots of good things. Again, it shows a marked reduction in fat mass was seen in the estrogen plus testosterone group. And anybody that knows me knows that I want to decrease fat mass. I want to increase muscle, decrease fat mass. So again, good things. This slide right here, I think, means a tremendous amount. So really look at this slide, folks. 1 in 7 premenopausal women die from heart disease. Postmenopausal women, that number goes to 1 in 3. And I talk to all of my patients about this slide right here. And that's where I get on my soapbox, that women need estrogen replacement when they go through menopause. It's a must. And, again, everybody's worried about breast cancer. And again, and I'm not saying that that's not a worry. You should be concerned. It's part of being concerned about your health. But that's why we do, self breast exams. You go to your OBGYN once a year. You get mammograms. We look for those things. But again, cancer is number two, folks. Number one by far is cardiovascular disease and stroke. So our mission needs to be to prevent those in our patients. And in my opinion, prevention starts with getting your hormones replaced. Another benefit that you get from estrogen and testosterone, you have a decrease in Alzheimer's disease. Look at this. Women on estrogen are 50% less likely to develop Alzheimer's disease. So again, it's aging well, and that's what we want. So you need to have your hormones replaced. Osteoporosis, big deal. Testosterone actually showed an 8.3% increase in bone density. How about that? That's a pretty interesting study. And I can tell you, especially as an anesthesiologist, I see a tremendous number of fractures, and especially with our elderly, osteopenic, osteoporotic. They have you decrease in muscle mass. All those things lead to falls and fractures, and it's a big deal when you get older. This is very interesting, also. Again, I was talking to a patient today that has arthritis and fibromyalgia, and I was explaining to her how beneficial hormone replacement is going to be for her. And like this says right here, both estrogen and testosterone can stimulate precartilage cells, possibly reversing the development of arthritic tissue. That's really, really interesting. And the other thing that I really notice is that testosterone replacement and estrogen replacement seems to be really beneficial for my patients with fibromyalgia pains and that type of pain also. Now, obviously, you have different ways that you can replace these hormones. I do not recommend that estrogen be replaced by pills. Um, I know a lot of people use troches, which are sublingual. Again, my belief with that is, and I know people disagree with this, it's impossible for you to take a sublingual and not swallow some of that. I mean, I just don't believe that. So I'm not a big fan of troches either. So pills, patches, creams, gels, and pellets. We're going to be talking about pellets today. The things you have to worry about with the creams and gels are, number one, whether or not it's going to be absorbed well. You as the patient have to do a really good job of rubbing in these creams and gels over a long period of time to get good absorption. And it's difficult to do. So my predominant uh, my predominant way of giving these is by pellets. Again, this is oral estrogen therapy. Again, that's why I don't give oral estrogen therapy. Don't like it. Don't use it. Uh, you have to. That has to be metabolized. Has to go through your liver, and these are the things that you can run into: breast tenderness, endometrial cancer, uh, estrogen dominance, fluid retention, headaches, vaginal bleeding, leg cramps. I mean, it's just a long list. So why do that? Why, just, go to a different route. We talked about creams and gels, infecting other people in the house with your creams and gels. It's a problem. Pellets have been around a long time, folks. This is something I didn't realize. These things were developed in the 30s for women that had hysterectomies, and it was a predominant way of giving hormones, especially in Europe and Australia, prior to the invention of Premarin. Premarin kind of put a halt to pellets, because why would you go through the process of putting pellets in if you can get the same results by taking an oral estrogen? And that's what everybody did. The pellets have been, like I said, have been around a long time, safe, hundreds of studies, very clinically effective, and in my opinion, is the best way to get hormone replacement therapy. And the interesting thing about it, what I think is interesting anyway, is that the the education I got with my board certification and fellowship, the people that trained us in for many hours uh, were not advocates of pellets. So I had a bias against pellets. I was told that it was a unnecessary risk, surgical procedure, all of these different things, until I actually saw somebody put in pellets, and then I realized that there really is not a whole lot to this, and it's a very small incision, and you don't put any sutures in, few steri strips, and that's pretty much it. So the risk is very low. You know that you're getting good blood levels of hormone, which obviously is important to do the things that we want as far as brain protection, heart protection, breast protection, bone. You need to have good blood levels, and I feel like I get good blood levels and consistent blood levels with the pellets. So this is us, Personalized Wellness, Dr. Don Bonner. We're on Highway 51, 573 Highway 51, Suite D. We're in Ridgeland. Uh, we're on the second floor of a fourplex, an office fourplex. We've got two bright yellow Adirondack chairs out on the patio, right on the deck, I suppose, that are pretty easy to see, so a lot of people are able to see that. Our phone number is 601-898-0911. The website's www.thewelldoc.com. Check that out. I've got a lot of blogs on that site that you can see. You can go to the YouTube channel for Personalized Wellness, and a lot of videos on there. And the other thing is on Facebook. If you look up Personalized Wellness, my business site, I think there's 25 videos on there. So, a lot of education on there. So, like I said, check us out. And I think that we can help you. I have two different programs at the clinic real quick, and then I'll see if there's any questions. But basically, I have one program that's for the hormone replacement therapy pretty much only, and it's more streamlined. There's a consult involved and lab work, and then we put in the pellets, and there's no other charges as far as physician charges, after that. And then the other side of the program, I do what's called a metabolic reset program. A little more in-depth consult involved with that, and hormones are part of that program, but I go pretty deep into diet, nutrition, uh, fasting protocols, stress management, exercise. So just a lot more involved, and I see you monthly for 3 or 4 months usually to establish that program, and because I don't like to call it, part of that you will lose fat mass on that program, but I don't like to call it weight loss. And so anyway, that's what we do here. Give us a call, and we'll be more than happy to take care of you. So I don't see any questions right now, so we'll end this talk, and I will record this and put it up on the site, and also post it to YouTube also, and you can come back and watch it at a later date whenever you want to. But again, Dr. Don Bonner, I appreciate everybody for listening, and we'll see you next week. Thank you.